Good evening, everyone. Welcome to our EUROPREV webinar about screening for atrial fibrillation. I am Veerle Piesens. I'm a general practitioner from Belgium, and I'm very happy to welcome our two speakers for this evening, Dr. Christoffer Bjerre Haase and Professor Dr. John Brandt Brodersen. They will bring us a very interesting evening about screening for atrial fibrillation. But before we start, I have three announcements for you. So the first is that there will be attendance certificates available for those who attended this evening. So please make sure that you participate under your name so we can register you as attending. There is also a video recording of this webinar, which will be available along with the previous webinars at our website, europrev.eu. And a third announcement is about our forum, our 2026 forum that will take place in Madrid in March 26 and 27. Our Spanish colleagues made a nice video, but unfortunately, we cannot make the sound come through in this webinar, so please check it out at our website. It will be available over there. And also registration starts this Friday, so if you would like to participate as participant, just you can start registering from this Friday. You can also still supply some abstracts to present something. Deadline is 9th of January to submit an abstract. So, and then for this, now for this evening's webinar, so our first speaker will be Dr. Christoffer Bjerre Haase. He's a medical doctor specializing in general practice in Denmark, and he has a PhD from the University of Copenhagen and the Deakin University in Melbourne. And his research is based on sociology, philosophy of science, and evidence-based medicine, and is about how new forms of data change how we diagnose in the clinic. He will start this evening with talking about the evidence base for screening for atrial fibrillation. Professor Brodersen will continue. He is also a general practitioner and chief physician with more than 30 years of clinical experience. He holds a PhD in public health and psychometrics, and his work focuses on prevention, medical screening, overdiagnosis, overtreatment, overuse, over-medicalization, evidence-based medicine, and multimorbidity. He is based at Copenhagen University Hospital, and in addition, he holds a visiting professorship at the Research Unit for General Practice at the UiT, the Arctic University of Norway in Tromsø. Dr. Brodersen's research centers on improving our understanding of overdiagnosis and developing strategies to prevent it. His work also addresses the reduction of social inequities in health and the pursuit of more sustainable healthcare systems. He will talk about overdiagnosis in atrial fibrillation screening, and then Dr. Haase will take over again and explain to us what we can do as general practitioners when patients consult us with their own heart rhythm data. And we will end this evening with questions, of course, and answers from our speakers, but also with some compliments from us to them. I can already say that now, that we will do that later on. So the floor is yours. I will stop sharing and hope that you can take over.
Yes, thank you very
Yes.
much, Verle. It's a pleasure to be here. I'm sure John agrees to that. And thank you all for participating this evening. I will just try to multitask and share my screen at the same time. Let's see if it works. As people see the slide here, it's great.
Yeah.
So, as you described, Verle, we are going to talk about screening for atrial fibrillation in general practice. More specifically, we are aiming for new devices such as wearables, smartwatches, and so on, as this becomes more and more available for people to do without necessarily any involvement of doctors. So we have three major points today, or three themes. First, I will go through Johnson, my project, our study about atrial fibrillation screening with wearable-like technologies. Then John will take over and talk more generally about overdiagnosis in this regard. And then I will continue with some of my findings from my PhD, in which John was also a supervisor, about how GPs respond to patient-generated data in general practice. So let's start. First part, I will go through a short introduction, why this is important. And then I will go shortly through how we did our study. Then, of course, what did we find? And finally, so what? What are the implications of this? And you are very much welcome to join the discussion afterwards if you agree or have disagree or have any questions. This is a commercial from the latest Apple Watch, the Series 11, which is branded very intensively about being the ultimate way to watch your health. It has multiple commercials and points about how it's valuable for your health. So the crucial question here is, of course, is this actually a fact? Is this a medical fact, at least? Because if you look deeper into it, you will see that they brand themselves as being available to alert you for any heart irregularities, and then you can consult your doctor. But that's like the people like us, and I'm one of those doctors. Like, okay, what am I supposed to do with these data, right? If you continue looking, they also say that these watches, these wearables, are providing critical data for doctors and peace of mind of the user. And maybe they do provide peace of mind for the users, but I'm not sure they necessarily provide doctors critical data. And regarding atrial fibrillation, regarding the heart, one reason for this is that the current guidelines from the European Society of Cardiology, as well as the US Preventive Service Task Force, do not recommend systematic atrial fibrillation screening for any population. It is the case that they, for some subgroups, do recommend maybe some kind of opportunistic screening, but in overall, they do not screen or advise for screening. But this is, in fact, what's going on at the current situation. Now I can not change next slide. It says turn off participant navigation.
Maybe you can click on the picture, Christoffer, and then try the arrow. Doesn't work.
It doesn't work. I'll see.
Then
yeah, there it's
there it
going
comes.
to.
There it comes.
Okay. Good. Yes. So let's just say one thing is what the recommendation about screening. Yes, is if you look at the actual study in which they have. Okay, now it disappeared. I'll try to find it again. 1 second.
Okay.
No worries.
You're not alone in this.
All good.
There might be some delay. from when you press, because you went to slide 9. Now you're on slide 5. Perfect.
Yes.
Now there
Great.
are no slides. I don't see any slides now.
I see the slides. I see it in presentation mode.
Okay.
For at gøre det, skal du først tilføje som medlem i indstilling.
Okay. Yeah. Now it's okay.
Okay. I hope the rest also see the slides now. Otherwise,
I think
make
it's
a
a
comment.
delay. It's a delay. You and I are in Denmark, and the other people are anywhere in Europe. So just
Okay.
I will click on if there's problems. Just continue.
Yes. I'll try to do it slowly, and let's see. And people react. That's great. Thank you. So some of these points are from the actual study that has been investigating the use of Apple Watch for finding atrial fibrillation. And one point that they highlight is that out of more than 400 and almost 20,000 participants, 2,000 got a notification of a regular pulse. And in the end, it was 153 who were diagnosed with atrial fibrillation. So out of more than 2,000 participants who got the notification, it was only 153 who in the end got the diagnosis, which indicates that this could create a lot of noise in general practice setting. As they also highlight, this has not been designed to actually assess the watch as a screening tool, and it has not been investigated for its sensitivity and specificity of false positive results. And they also highlight further studies are needed to better understand the public health implications of identifying irregular pulse in person younger than 40 years of age. And they also say that there are great uncertainties about the benefits of diagnosing and treating asymptomatic atrial fibrillation. And finally, they say that further clinical studies are needed. And all of this is, of course, because this is a new situation in which people are actually healthy. They are continuously measured and screened for atrial fibrillation. And this provides a new situation where we simply don't know if what we are finding is, in fact, something that is useful for patients to be treated for. So therefore, we made this study where we had this simple research question. Do wearable technologies improve diagnostic accuracy and patient-relevant patient outcomes? Or do they increase atrial fibrillation prevalence without leading to meaningful improvements in outcomes, thereby contributing to overdiagnosis? In other words, did we actually see some significant outcomes, or did we not find any significant outcomes which indicate overdiagnosis? We searched at PubMed, and we did an analysis, meta-analysis with statistical method we can go into in the discussion if you want. But basically, the inclusion criteria was pretty simple. Of course, people were supposed not to have an atrial fibrillation diagnosis before. It's fine if they had elevated risk to have it. We had to make some kind of level needed of several ECG recordings. Otherwise, everybody who has just made one simple recording could be, which is not applicable for these kind of technologies. And the exclusion criteria was if people already have had a stroke or embolism, if they were already on the therapy, or if it was some small specific studies that they were investigated for specific smaller effects. And the primary outcomes I will show in the next slide, which are the results. These are the results we got. I'll go through it slowly for everybody to understand it. Basically, we saw in the study that 60% of the atrial fibrillation diagnoses regarding intermittent screening, which means that they were not continuously screened, were overdiagnoses, while 65% among those who had continuously screening. And what you can see on the table to the right, this is also to explain the method we had. You can see that you had those who were continuously screened had almost 3 times as higher risk to get the diagnosis. And among those intermittent screening, they had 1.88. The crucial thing here is to say, did they actually get some treatment for it? And you can see that among those who got continuously screened, they had double up risk of getting into anticoagulant treatment among those continuously, while intermittent was 1.84. And what is relevant here is, of course, to see, did this actually have any effect of those who got screened? So that means that we should see a decrease in all-cause death or in some significant clinical relevant outcomes. But as you can see, among those continuously screened, the all-cause death was, or the risk score was 0.94, and it was not significant. It was basically the same as the control group, the same with the intermittent group. And you also see that there was insignificant when it came to stroke and systemic emboli and bleeding. In other words, there was a higher risk of getting the diagnosis, but we didn't see any effect on those critical outcomes that we were hoping to see a reduction of. There was a small effect if you combined all the different outcomes. As you can see, it was 0.9, but insignificant among the continuous screened, and just about significant when it was to the intermittent screening. And combined, you see that there is a small positive effect of being screened, but that was only if you combined all the different kind of negative outcomes. So in our studies, we had some clear limitations. First of all, we did not investigate actual Apple Watch or other modern wearables. We used wearable-like technologies, which is, for example, the Holter, a classical screening diagnostic tool in cardiology. And basically, we are limited of the limitations of these studies that were investigated. And for example, only 3 of the 6 studies had follow-up periods beyond the screening phase, and those periods were rather short. They were 2.5, 3, and 7 years. And only 2 of the 6 studies had participant blindings. And those 6 studies were very different in their methodology, and they had they have focus on older patients than what we can expect from many of these users of wearables. Nevertheless, our study suggests that there is a high degree of overdiagnosis, but there's also a high degree of uncertainty about the effect of these studies, these technologies. So what is needed is randomized controlled trials to actually investigate long follow-ups of these new technologies. And it's also overall difficult to say if it has any positive effect on the public health. So there is also the need to more focus on regulation, including accountability of these, what has also been described as wellness technologies, because they are not officially certified as diagnostic tools. So finally, regarding this part of the presentation, the conclusion of our study was that there was, when people were continuously screened for atrial fibrillation, among high-risk population, we also almost saw a triple of atrial fibrillation rates. Without these patients were not significantly improved their outcomes. But it remains a hypothesis among the general population, especially those with low risk simply because nobody is investigating these kind of technologies. Thank you. And now John will take over from here.
Thank you, Christoffer. If you take the next slide. So by overdiagnosis, we define it as broadly, overdiagnosis means making people patients unnecessarily. And you can go even further and say it's by identifying problems that we're never going to cause harm. And in this case, it's atrial fibrillation. Or you can also talk about medicalizing ordinary life experiences through expanded definition of diseases. So when we as researchers look for overdiagnosis, we are looking at deviations, abnormalities, risk factors, or pathology. And in this case, it's abnormalities in ECGs, and those abnormalities are then defined as atrial fibrillation. Next slide, please. Overdiagnosis is not a false positive result. Overdiagnosis often lead to overtreatment. Overdiagnosis can be caused by too much testing, overuse. Overdiagnosis and misdiagnosis are two different concepts. Overdiagnosis fulfills all the diagnostic criteria, while a misdiagnosis do not. Incidental findings can, in many cases, lead to overdiagnosis. Christoffer and I also think underdiagnosis is a great problem. However, it's not always vice versa or contradictory or something that is opposite to each other. And just to make it clear, when we see unwanted clinical variation, it's often not caused by overdiagnosis. Next slide, please. When we do research in overdiagnosis, we often talk about 3 types of overdiagnosis or 2 types and then a special case. First, I will say something about overdetection, so please, next slide. Overdetection is found due to the heterogeneity in the natural history of the condition we are finding. So in this case, you could have a cancer cell, and on the y-axis, you can see the first abnormal cell. Then further up, you can see the threshold for where you get symptoms, and then when the person dies from the cancer. And person A has a very fast-growing cancer. Person B is a more slow-growing cancer, while person C, D, and E have either non-progressive or very slow cancers. Because the mortality among human beings are 100%, then sometimes you have a cancer in your body when you die, but you have never reached the level of symptoms. And this is the case for C, D, and E. And if you go and monitor those people, for example, with a smartwatch, then you would be able to find abnormalities of among those people. However, they will never get symptoms from the case. So that could be, in this case, atrial fibrillation that we are talking about. Next slide, please. Animals are often used to also explain it. So here you have the fast-growing as a bird, the slow-growing as a bear, and then the slow-growing or non-progressive ones are either turtles or snails. Next slide, please. In this case, this is from the Danish randomized control trial on low-dose CT screening for lung cancer. Here you see a male participant, and he had this lung nodule in 2005 and was followed in the screening program for 4 years and finally got surgery and biopsy, and he had invasive breast cancer. This is, invasive lung cancer. This is a case where you could think about overdiagnosis. However, you don't know what happens in the future for this person, so you don't know if he will ever get symptoms from this nodule, and you don't know if he will die from it. But this is a typical example of a very slow-growing or non-progressive condition. And this is the case in lung cancer screening, you have those heavy smokers that are participating. They have a very, very high risk of other causes of death, like cardiovascular diseases. So if this person dies from a stroke during those 4 years, then the person would have been overdiagnosed. Next slide, please. Here you have the same with breast cancer. This is a woman, and she goes to 4 mammography screenings in 8 years, and nothing is really changing. But finally, she has a biopsy, and she has invasive breast cancer. Next slide, please. Here I have an extended model of the same as the animals. So here you have 5 screening rounds at the x-axis. The first threshold is symptoms, then is detection rate. The next is symptoms, and the last is death. So if you go for the next slide, Christoffer, then you see the first abnormal cell here, and next slide, detection threshold, next slide, symptom threshold, and next slide. This is where you die from the cancer, and next slide. And here you have the all-cause mortality because it's 100%, so someday all our people in the model will die. And here you have the same person F has been overdiagnosed. Why? Because person F was found in the 5th round. If you look at the x-axis, then you can see you find the person in the 5th round. However, the person never develops symptoms and dies from other reason. Then you also have person I, who has a spontaneous remission of the condition. And in this case, it could be dysplasia on the cervical organ in women. It could also be those rare cancers that children can get, neuroblastoma. It could also be, in our case, a short period in your life where you have atrial fibrillation, and maybe you have it for some months, and then you don't have it evermore. So here in this model, you see that the natural history of the condition has to do with overdiagnosis, and the more slow-growing you have a condition, or non-progressive, or even spontaneous remission, the higher risk you have for overdiagnosis. However, this is only one of 4 explanations. The second one is competing risk of dying. So if you have very old people you're screening, or you have people that have a very high risk of dying from other reasons, then next slide, Christoffer. You see that I have now moved when you are dying in my model, and this will then have the cause that person D and E are overdiagnosed. Next slide. So competing risk of dying and the natural history are the 2 of the 4 causes. Next cause is the sensitivity of your test. So if you have a very high resolution in an imaging, or you have a very sensitive biomarker, then you have to lower the threshold for where you can find it, and that's shown in the next slide. So next slide. And here I put down the threshold for where I can find an abnormality, and next slide. And now person G is also overdiagnosed. And next slide. And this was Christoffer's results from our study. And the reason why I'm showing you this is you have to look at the 3 meta-analysis on the left lower corner. Here you have 3 diamonds. And if you look at the high one, then in the intermittent screening, where you only screen now and then you find around 1.8 more atrial fibrillation. However, if you do continuous screening, that's the middle diamond, then you find nearly 3 times as much. So that's the 4th reason. So not only the sensitivity of your test, but also are you doing rarely testing, or every second year testing, or are you doing continuous testing? Next slide. This is an illustration of overdiagnosis in throat cancer from South Korea. And the reason to this overdiagnosis was that the health minister encourage the GPs to buy ultrasound equipment and do ultrasound examinations. And you can see that they did so because they 7 or 8 doubled the incidence of forehead cancer. Please look at the mortality of forehead cancer at the x-axis. It doesn't change at all. So this is a beautiful illustration of overdiagnosis. Next slide, please. It has become a global problem, and WHO in France, in Lyon, IAC, has done a study on looking on several countries, and you can see that it's not only South Korea that is in the lower right corner, but a lot of countries where we see the same pattern with an increased incidence and no change in mortality. Next slide, please. The problem around overdiagnosis is that the survival rate will be 100% due to the definition of overdiagnosis. And this means that the more overdiagnosis we have, the more survival stories we will have. And then people, lay people and politicians, patient organizations will start talking about those survival stories. And then it looks like continuous monitoring, early detection, screening looks very efficient. And then they will plead for that. And then in our societies, we will implement more of those technologies. And then you have this evil circle called the popularity paradox. It's unfortunately not me that invented this great illustration. It's Muir Gray and Angela Raffel that wrote about this in their 2007 book. Next slide, please. Paul Glasgow has looked at the degree of overdiagnosis in Australia as a country. And here you have all women with cancer diagnosis. And you can see that 4 cancers are driving most of the overdiagnosis. It's thoracic cancer, renal cancer, melanoma, and breast cancer. And the red area of the big figure at the bottom, combined cancers, is covering 18% of all cancers. So nearly 1 in 5 women are overdiagnosed with cancer in Australia. And next slide. This is men. And because prostate cancer is more overdiagnosed than breast cancer, then you actually have 24% overdiagnosis of males in Australia. So we are up to nearly 1 in 4. Next slide, please. It brings inequity to our society. It actually distributes our resources to those that are at least need. This is illustrated by Wilson Fisher in US here. You have the same cancers: breast cancer, prostate cancer, thoracic cancer, and melanoma. And you can see that the mortality of those 4 cancers are the same, no matter if you live in a low-income county or if you live in a high-income county. However, there are much more diagnosis in the high-income counties, and the simple reason is health insurance, clinical activity, and screening programs that are producing overdiagnosed people. Next slide. As a short presentation of overdefinition where you define too much. Next slide. Here you see what will happen if you apply the European cardiologist guidelines made in 2007 to a healthy, to an ordinary population in Norway. I have to emphasize that Norwegians are among the longest living and most healthy people in Europe. And you can see here, if you apply this guideline to this Norwegian population, then around 4% are healthy and the rest are at elevated risk. I don't know if you know it, but since 2007, the guidelines have changed and we have lowered the thresholds for cholesterol and latest for blood pressure. So now it is recommended that all people under 80 have to have a blood pressure of 130/80. In this case, it was 140/90. So my guess is that if Halvdan Peterson did this analysis again in Norway, you would have no healthy people left. Next slide, please. Before I show the last slide, I just want to say that over-definition is also in play in atrial fibrillation screening, because it depends on how you define atrial fibrillation when you do these screening situations. So should you have atrial fibrillation for 10 seconds, 20 seconds, 30 seconds, and how often should you have those attacks? So it's also a matter of definition. But the final slide will be about disease mongering, so where you invent new diseases, and here you have some cases. Christoffer and I did a nice paper you can read in BMJ about sarcopenia with our nice colleague Jakob, and there are also other conditions here to laugh of, for example, road rage disorder or low T or dry eye syndrome. When we were having the Vonca Europe conference in Brussels in 2023, there was actually an announcement from a medical firm producing those eye drops for dry eye syndrome, and they recommended all GPs to talk about dry eye syndrome with their patients. But what was for me very funny was that they emphasized that this condition can be asymptomatic. So I think it's really how should I even diagnose this condition? I don't know. But over to Christoffer. I think the next slide is yours.
Thank you, John. So we have now gone through the study of atrial fibrillation and overdiagnosis in general, and now I'd like to present some of the results from my PhD about how GPs respond to patient-generated data in general practice and which kind of conflicts there might be involved in this. So again, I'll go through why is this important as an introduction, how did we do, what did we find, and again, so what are the implications, what are the consequences from here, and that would be also the opening for the further discussion we can have, all of us. So why is this important? I'll just point out two reasons for this. That is because of the data ambitions among policymakers and commercial companies that are all influencing the general practice setting. I'll just take an example from Denmark. We are one of those countries that are highly using data in general. We have had specific personal identification since the 60s, and everything goes online and through data in Denmark. And one of the reasons the politicians ask for more use of data in general practice is for the argument that because the Danes want it, as this official paper describes, it is a political ambition in Denmark that Denmark must become the leading health tech nation in the world. The task is to boost digital healthcare collaboration for every patient in Denmark. And the reason is to optimize and facilitate workflows for the GPs and the patients to free up time and space for other tasks in the clinic. And the overall goal is that we can reduce with 1 out of 3 consultations, actual physical consultations, they can turn into digital alternatives instead. And why this is relevant for all of you is because very often Denmark, when it comes to data, has been in the forefront. So what we are experiencing in Denmark could be the case, or is much likely the case in other countries as well, when they start being as digital as we are in Denmark. And another reason why you should expect this in any country in Europe is because this is a part of the European strategy for data, that we are supposed to use much more data among different actors and in between countries, and this includes very much health data. And as you can see here, the idea, the hope is that we simply by using our wearables, our watches, our phones, we can start diagnosing and see effects of treatment, and we can share these data in between different actors, not even within the country, but different countries within Europe. And again, we have this hope in the European Union that we can save a lot of resources, a lot of money. It is expected, without any evidence for this claim, that we can save 120 billion euros in just the health sector per year if we start using more data. And that was just the political reason. You can see the commercial reasons. I already mentioned Apple. And one reason to mention Apple is that they state that their greatest contribution to mankind will be about health. Because they have realized, as many other commercial actors, that this is a field in which there are great opportunities. You can also see this is from the American Amazon, that healthcare is now something you can do online instead. There are multiple diagnoses, conditions that you can simply just treat online instead, including conditions that you would normally consider being a task for GPs because of the risk of other conditions than the most obvious. So just some of the problems with this new development is that many of these data are not tested according to the standard that we would hope or expect, and simply that evidence-based medicine has problems keeping up with the development, and that the manufacturers, they are branding their products as beneficial without actually investigating if they have any positive clinical outcomes. What are the local contexts within the, let's say, the healthcare system in the specific country? And also, what are the negative effects of these technologies? There are very little regulation on this, and that's because it is considered low risk. And again, we as doctors nevertheless have to consider when people bring their data and their health data, we still need to consider all the medical, scientific methodology, such as validity, spectrum bias, the test probabilities, the risk of false positive or negative results. Is this actually a way of do screening? What are the risks of overdiagnosis, overtreatment? We can also start in making too many referrals to other doctors and waste a lot of resources, as John mentioned, and also increase the social inequality in health in general by simply wasting the resources on something that has little positive effect. So that's why we wanted to investigate, John, me, and our colleagues, how GPs respond to these kind of new data. So basically, our research question was, how do GP respond to and use patient-generated data, and compared it to how do policy ambitions relate to everyday clinical work? And this was a qualitative study. We emailed 80 GPs in Denmark. 23 wanted to join. 13 of them were women, 10 men. They had a wide range of age and also very different kind of clinics. Some in areas where people are more privileged regarding their health and financial situations, others in more rural area where they have more challenges. We did 3 pilot interviews before we interviewed them. And the interviews were in 2021. They were qualitative, semi-structured, one-to-one, open-ended, in-depth, situated questions. And what did we find? If I should mention one point that we found that is crucial for all of this, and use it with an example, an empirical example from the interviews, it was this quote from a GP. He was 63, he was very skilled, and he said, there is actually an elderly woman who lived in Panama, I think. She's a nurse, and she comes with some kind of watch saying, my watch said I had arrhythmia or something. I wonder if I sent her to a cardiologist. I would think so, or downplayed it a bit. And this is like a crucial element to the whole use of data, because what you can see in this quote is that he either because of the data from the patient, either he spent resources by referring the patient to a very highly specialized doctor, or he chose the very opposite and didn't do anything. And this is a key element because it shows that the GPs, in order to use these kind of data, they need to do a lot of contextualization, recontextualization about the work before they could use them in the clinic. So this actually meant that data were not used simply as an answer to any questions. In fact, data had to be, it was more compared to symptoms, that sometimes, you know, the symptom is indicating a severe disease. Sometimes the same symptom actually shows something that is not severe or dangerous. And it is the clinical situation, not the quality or validity of the data, that actually determined how the GP responded to patients' data. And data are not used as simple measurements. Actually, the GPs rarely actually looked at the data. They just heard from the patient what they have done, and then the GPs just did what they normally would do. And back then in 2021, it was pretty rare that people were bringing these data. It might have changed since. And it was mainly step counts, heart and sleep data, such as the atrial fibrillation data, or data from online mental conditions or lab tests that they were looking at. And why is this relevant? Again, we had a perspective both from the clinical perspective and from the more healthcare, health policy perspective, because those two fields are interwoven, meaning that we are, as GPs, are affected by the political conditions that we are working under. And we found that those data were strikingly limited, useful by themselves. The doctor had to spend a lot of time and resources before they could actually use those data. And again, there was the clinical context that determined whether these data were actually useful or not. And that took time from other tasks. If you as a doctor need to spend time looking at or talking with the patients about their data, you start spending time on that instead of actually investigating the patient, or you might not have as much time with other patients instead. And importantly, the GPs were on their own to make judgment about these data, because there are no guidelines about this. There are very little knowledge, evidence about how to do this. So each GP is kind of on their own when it comes to these kind of problems. And very often we hear that the patients are empowered. They actually have the ability to now investigate and do something about their health. But at least according to the GPs we interviewed, they did not have the experience that their patients were empowered by these data. In contrast, they might be feeling less empowered because simply neither the patient or the GP knew what to do. And if data therefore should be used, it requires that the GP has better working conditions to actually have time to look at these data. They also need more formal education in what kind of data can be used for what. And there's also a need for a more collective approach and attitude to when are these data legitimate to bring into the clinical setting. And that's also required that we delegate explicitly the accountability of these data, who are actually accountable for what data shows. At the moment, it's the GP who are responsible of the consequences that these data create. And there is needed to a more political public debate about health priorities, if one should spend the focus on data rather than those who are having symptoms. And also, again, more focus on commercial and political responsibilities, including regulations, because at the moment it's very limited, the regulations. And in a Danish context, we have provided this simple guide to use of wearable data, where we say that at least to keep it very simple and to use for various kind of data, one simple way to do it is actually to look at the measured data, actually get a sense of what is it that the patients are providing, how do they measure it? And then when you actually look at the data, first of all, consider the data. Are they accurate? Do you believe that the device is having the ability to measure correctly? Do you think the patient has the capacity to measure it correctly? And if you believe that the data are actually accurate, then consider, do you feel equipped, ready to interpret these data? Do you know how to use it regarding the specific diagnosis? Do you know how to use it for the specific patient, such as a young patient or a multimorbid patient? And in both cases, you should consider, how do you justify your answer? Is it something that you actually believe that you have evidence to behind your thoughts? And if you are in doubt on any of these, maybe you could consider that maybe you should just continue what you're doing already, what you would do if the patient did not provide that data. So that was our presentation, first about atrial fibrillation specifically, then about overdiagnosis generally, and then some perspectives on how GPs in a Danish setting with a lot of data around them actually acts on this and why they do it and what would be the implications. Thank you.
So thank you very much, Christoffer and John. Let's see if we manage now again to give an applause. Yes, okay, there is an applause button in also in Teams. So thank you very much. I don't know. I think there were no questions in the chat right now, but let me see if someone has a question. No question, but a compliment. And as I promised, it were questions and compliments that were promised. So this presentation opened up some great horizons, especially in the field of digital health. Thank you very much. So this was our first compliment. So Carlos, do you have a question? I cannot hear you, Carlos, but no, cannot hear.
Christoffer, could you stop sharing? Then,
Yes, I'm looking how. Oh, there is the button. There it is. Okay.
Okay.
We can unfortunately not hear you, Carlos. Maybe there are other questions until the technique is working.
No. Yeah. Okay, so perhaps I have a question. So Christoffer, the qualitative interview you did was about all data patients provide, not only about heart rhythm data. Yeah, were there a lot do heart rhythm data provided in your digital immersion society?
It's a very good question, and we were surprised how little patients, according to the GPs we asked, actually experience these situations.
Yeah.
They mentioned that it was maybe monthly, and often people were just mentioning like that they now use these apps and so on, that they didn't really provide it. When they did, it was the atrial fibrillation, it was something about heart rhythm and sleep disorder specifically.
Mm-hmm.
But this is actually this has happened several times with this kind of research, that sometimes research is before they're too fast to investigate
Yeah.
these kind of things. So it might
Yeah.
have the same thing was the case with the more like genetic problems and healthcare, that you have a lot of research in sociology about how did people react on the genetic testing and so on, and they were before it turns really popular to do so. So it might have changed today if we did the same study today, that people are using it more
Yeah.
often, or maybe simply they don't, and we still see this discrepancy between the political ambitions of how much it can be used and how people are actually using it. Or they simply go to someone else than the GPs with if they have these measurements.
Yeah, perhaps they go to the cardiologist because
In Denmark, that's also one of the reasons why it's really good to investigate with GPs, is because the GPs are the gatekeepers in Denmark, also for the cardiologist. So we don't expect so. But again, a lot might have changed in those 4 or 5 years.
Yeah. Okay, let me see what people say in the chat. Carlos, let me know if your struggle with the audio has resolved. No? Can you say already something? Yeah, you say, but we don't hear. Okay, so Taha Tuxan Milan says, thanks for the presentation. It seems like we need to reduce the weight of the textbook information and increase the weight of the patient's actual feelings in our decision making. And then there's a question, any tips on managing concerns of patients on these findings on a tight schedule? Any feedback from the patients published or planned? Any economical waste studies to come? I feel politicians respond to that as they have a lot of pressure to appease patients groups with some new technology to cover for the lack of access. I don't know if
I would like to say one comment around this.
Yeah.
And I think it's about our regulation, because we are not regulating technology at all. And I mean, Christoffer did a study in general practice about patients coming with data. But we see more and more engineers developing diagnostic apps on all kinds of issues. Also depression scales, anxiety scales, melanoma screening, etc., etc., etc. So from a more meta level, I think we need to start considering to regulate those markets. And if we don't do that, I think it's going to be the end of having healthy people in our societies. And it will crash our healthcare systems totally. Because if people are examining themselves with all kinds of technologies, they will find abnormalities. So I don't think we will have resources in our societies to help with this. Christopher and I also participated in a research group where we read articles together. And now there are people suggesting that we need a new profession. We need a profession of people that are able to look at those data and interpret those data. But I think there's such a huge need for people and monitoring their health. So if we don't regulate the market, I think it's going to be a tsunami of needs and expectations.
Okay, thank you,
And
John.
if I can just add to that, I think it's also fair for the GPs to make it clear that as long as there are no regulation on this market, and as long as there's so much different kind of data out there, it's fair to make it clear for the patient that we simply don't know if there is a positive effect of it, and that we do know that there are potential bad effects of the treatment and so on. Just like we cannot be clear what kind of supplements people are taking of different kind of pills and other drugs not prescribed by the doctor, then this is the same thing with these kind of data.
Yeah.
And there's a question in the chat around AI, and I've done some research in AI, and the problem is that people don't take into account that diagnostic test accuracy studies cannot be used anymore. Because if you have overdiagnosis, then your sensitivity will increase, your positive predictive will increase, and this means that we cannot do cross-sectional diagnostic studies anymore. We need randomized studies with a long follow-up, as Christoffer showed us, because we need to include the prognosis. So because we have so much technology now, and it has this very high sensitivity, and because it's very easy to access, it's quite cheap, and we can monitor 24/7, then we will find all kinds of things. So if we don't start doing proper research around this, then we will make a mistake and think that all these technologies are super sensitive and it's really good with this high diagnostic test accuracy, but we can't distinguish between correct diagnosis and overdiagnosis.
Two more questions in the chat. I think the first one is about the benefits of the screening. So are there results about the cerebrovascular and pulmonary diseases that they, I suppose, prevent compared with the costs with and without screening? So, yeah.
I'm not quite sure what the question is.
Yeah. So as I interpret the question, what is the cost effectiveness of screening for AF on cerebrovascular and pulmonary outcomes with screening compared with no screening?
You want to answer that, Christoffer?
No, you do
I
that,
did
John,
not
you know more
understood
about
the
it.
question properly, please let me know.
As Christoffer showed in our results, we could not see that people have any benefits from getting the diagnosis of atrial fibrillation via screening and getting treatment. So we cannot see any statistical significant decreases of all adverse events. So this anticoagulation treatment is not making any differences. So the problem is that anticoagulation treatment is not a treatment without side effects. So besides the labeling effect that you will get a diagnosis you don't need, you will also get a treatment you don't need that can give you some side effects. So this is, of course, not financially a plus. It's a minus. It's an extra cost.
Yeah. And then Carlos has given up, I think, to try to make his microphone work. So he has written that the European Society of Cardiology guidelines recommends screening for AF with ECG in all people aged more than 75. So do you agree with this recommendation?
I'm not strong enough in the specific evidence regarding screening this specific population to have a strong opinion about it. I would be surprised if they have actually investigated the risk of overdiagnosis and having enough data on long-term follow-up to actually provide evidence for this claim. But that's just but I'm not sure, again, I'm not strong enough into this specific.
Yeah.
What about you, John? Do you have any?
I would say that we don't have any really good direct evidence conducting a randomized control trial on the issue Carlos is raising. However, I think that the studies we have gone through are a very valid indirect evidence with different types of screening, and none of them are showing any benefits. Some of them are not showing any harms or very little harm. So I don't see in the indirect evidence any indications that the recommendations from the European cardiologists that we should do ECG screening in general practice on over a certain age is supported by our indirect evidence. It's actually not supported by the indirect evidence. But of course, we should have some randomized studies. But until then, I would not do it. I would because I would be concerned that I did harm. And primum non nocere, first of all, do no harm, is a super important ethics in general practice. So when we don't have any evidence supporting a potentially harmful intervention, I don't think we should do it.
Okay. Thank you, John and Christoffer. So perhaps a bit challenge, someone who challenges your position. It would be good if he or she could try to speak. So Benji Tor says, I believe in our country we actually need screening for atrial fibrillation in younger age groups. Benji, I don't know if you are able to take the mic and explain a bit, but perhaps it does not work. I don't know. So,
from a risk perspective, our hypothesis from all kinds of randomized studies would be that if you take a low risk group and did the screening in the trials that we have found, then the benefits would be even smaller and relatively the harms would be greater. So I think that if we will never get any more evidence than what we have found, then my hypothesis would be that if you go to a younger age group, then you would do even more harm than benefits.
And Carolina is curious whether there are also some patient data or citizen data available, and she wonders if people who can deal with their mortality and know that life eventually will come to an end, and when they have meaningful lives, if perhaps these people are less susceptible to the call of all these data wearables, and if they can resist this without a loss of quality in life. I don't know if you know about the lay people's perception of it.
There is a lot of literature about patients' involvement and effects on these kind of things, and it goes in various directions depending on the kind of the conditions and so on. But in general, you could say both among patients and doctors, one should not underplay how data do affect you emotionally if you measure something. I mean, even some of the GPs I was interviewing mentioned that when they saw that they haven't been walking enough steps during the day, they simply went out and walked further just to reach the 10,000 steps per day, despite there is no evidence that you need 10,000 steps. And this doctor knew that. But simply the fact that you see those numbers in front of you does have a huge effect on you. And of course, it all depends on the condition, the circumstances, if there is a conflict between the patient and the doctor. If the data are showing something positive, right, then everybody can be happy about it. But it does have a great impact on people, data in general.
Yeah.
I can only support what Christoffer is saying, and I have done some research around it, and I also have written the first ever textbook for university students on overdiagnosis. There was in one of the slides from Christoffer, there was a reference to the book. It's only in Danish for now, but hopefully next year it will become published in English. And in the book, we also trying to explain that fear of death is a strong driver to these kinds of measurements, self-monitoring. And we use Baumann as a philosopher to explain that this fear of dying can steer people into all kinds of thinking around earlier is better, more is better, etc., etc. But the great paradox here is that the more you try to control death, the more uncertainty you actually create. But we have in Denmark, we have access to all our blood tests via our own private homepage, via our health insurance. And we have also seen that this access to all the numbers is actually creating a lot of fear in our society, and people are asking for consultations with their GP because they are really worried about their blood tests. So it's not easy for lay people to interpret medical knowledge.
Okay, so and then perhaps a last question from Xenia, who has tried very, very, very hard to share this webinar through all kinds of links. So Xenia writes, I cannot imagine AF screening in my practice based on an ECG, as it sometimes occurs only as paroxysmal AF. For me, this means that if AF is not present when the ECG is recorded, I cannot rule out its presence. So, any reflections on that?
Yeah, of course, I agree that you can never rule out anything among asymptomatic people. I mean, we can all have some abnormalities and deviations, but I think that Christoffer's and my research and our presentation shows that as long as people are asymptomatic, I think we as GPs should be more calm and relaxed. It's a totally different situation when people come with symptoms and this impairment and have some significant problems. But that's in a diagnostic context, and it's totally different from screening.
Indeed.
And that is clear even in the evidence or the studies about the Apple Watch and so on as well. They also make it very clear that you simply do not know what the effect of these paroxysmal atrial fibrillation actually do to the patients long term, right? If it has any negative effect.
Yeah. So we don't know what is what risk do they bring, these paroxysmal atrial fibrillation. It is low, I think. Yeah.
But
Okay.
of course, again, then you could have a patient saying, when I walk to the third level to my apartment, I sometimes get really short breath and I have to sit down, and then my heart beats a lot and it's very non-regular. I mean, that's a symptom, and then it's not screening anymore. So it's very important that we are talking about screening in asymptomatic people.
Okay, so the questions are coming now. So a last one. I experienced some disconnections due to a microphone issue. No problem. Has the number of patients diagnosed with AF increased in your primary care setting after COVID-19? And do you recommend screening patients with a history of cardiac disease for AF? I don't know if you will be, perhaps this is out of your research expertise, but
I cannot answer the first question. I don't know if you can, Christoffer.
It's a good question. I don't know.
And then when it comes to patients with a history of cardiac diseases, I mean, there are maybe 200 or 300 cardiac diseases, so it's really hard to answer that question. But in some of the randomized studies that Christoffer showed, some of these people are high-risk individuals. So people have elevated blood pressure or elevated cholesterol, or have known arteriosclerosis, or have type 2 diabetes. And in these people, it did not benefit anything.
yeah. And with these words, I would like to close the webinar and thank you both very much for your interesting talks and for the answers to these broad questions. Thank you very much, and also thank you to our audience from all over Europe to be present and to bring us to participate in the discussion and bring us so much interesting questions. So I wish you a very good evening, a good night for you in Turkey already. And I hope we can all welcome you in March in Madrid for our 2026 EUROPREV Forum. Have a good night.